So, good morning, friends. Welcome back to Saturday Club of Baroda morning meeting. Very good to see you a large number joining early in the morning. And that's because of popularity of Dr. Anand P. Ambali. He is a unique guest speaker for us because he is expert in geriatric medicine and we don't see many of such experts around here. So to briefly introduce him, he is a geriatric medicine expert from Vijaypura. He is professor and head Department of Geriatrics, Sri B.M. Patil Medical College Hospital and RC Research Center, that is Vijaypura. He is MD, PGDGM, MSc, Dementia, FGSI, FICP, FIACM, and FRCP qualifications to his credit. He is adjunct faculty, medical education faculty, TAPAS, that is a Government of India initiative. He is Vice President, Geriatric Society of India from 21 to 24. He was awarded State Award from Government of Karnataka in the year 2016 and Commonwealth Scholar, University of Stirling, Scotland. He is going to talk to us about polypharmacy in older people. Exactly a year back, he talked to us regarding fall in elderly people, and it was one of the most popular talks on Saturday Club with maximum number of views so far. So thank you, Anand, once again for joining us, and we look forward to a very informative talk from you. So over to you. Thank you.
Thank you so much, sir. Very good morning, all the senior esteemed members of this esteemed club, Saturday Club of Baroda. Definitely it is a privilege to be a part of this program. And I thank Dr. Satish Panda, sir, and all his team members for having me again after 1 year for this on this platform. I have my colleagues and some students also joining this program. So we will be discussing about polypharmacy in older people in next 40 minutes. Most of the older people, they say that even if physicians, they say more the numbers of diseases, so more is the number of medicines. Okay, but that is not true every time. And that should not be the notion every time. So we will next 40 minutes, we will discuss polypharmacy. It is not just the number game, it is beyond that. In geriatric practice, apart from numbers, we also consider the adverse drug events, effects, reactions that occurs as a part of polypharmacy and irrational combinations and cascades. So we will go through these terminologies in detail in the next few minutes. And the most important aspect in geriatric care is the compliance. So it is very, very important for your treatment to succeed in the older people. Compliance has to be there, and how polypharmacy affect it. Okay, so most of the older people may prefer to take the medicines which are cheaper or which are more colorful than which are really required. They prefer multivitamins rather than taking an clopidogrel. So that has to be kept in mind. And knowing all these things, there is a polypharmacy, there is non-compliance, the events are happening, adverse events are happening. We should know how to de-prescribe also. So this is what I have planned to discuss, and we will go step by step. So I quote Sir William Osler long back. He said, imperative drugging, the ordering of medicine in any and every malady, this polypharmacy, is no longer regarded as a chief function of a doctor. So this was, I unquote this, and mentioned by William Osler, sir, long back, 100 years back. And still it holds true, but now there are many issues that drags the clinician to be a part of polypharmacy or irrational polypharmacy, and how to overcome that we will discuss. Now, this is just an case scenario. I'm just telling you, we are not interested from where this prescription has come. But if you look at this prescription, it has 22 medicines, right? And if you look at the red dots, This esomeprazole is there, and ranitidine and domperidone is there. Two H2 blockers and antacids are there. Then if you look at the blue dots, okay, so the blue dot are one is one is constipating agent, another is a laxative agent that is being used. Then we have the yellow dots. So if you see that there are 6 yellow dots, 1, 2, 3, 5, or 5 yellow dots, all that contains one or the other form of multivitamins, minerals, antioxidants, and even the powder that contains all these things. So what is happening here is maybe it's definitely irrational polypharmacy, and 22 medicines persons to be taking every day. That reminds us that what Hippocrates used to say, let food be thy medicine and medicine be thy food. So if these older people, when they come to our geriatric OPD, if you just ask how is your appetite and why is that your food intake has come down, the obvious answer is, sir, इससे पेट भर जाता है, ये गोली निगलने में पेट भर जाता है, इसके साथ जो पानी पीते हैं बस इसके साथ. So that is how the things move. Look at another example that we get in our OPD, the jugaad, what happens, that is what we call. When we ask the older person that how is that you are managing medicines, then he just threw these medicines on my table and he said, this is how I manage. See, those are the tablets which are folded, they are being cut into pieces, and they have been distributed by the children in the way that the color with the red one, this should be taken in the morning, the other one in the afternoon, and the one in such strips are taken in the night. So somehow the older people in India get adjusted and they make some or the other way to ensure that medicines are taken correctly, and somehow I don't know how correctly they will be taking these medicines. So when we prescribe for any age group, for prescribe as a physician or a consultant, when we prescribe for the patients, what we look for. So what we look for the patients in assess the patient and define the functional goals, what we are planning to do for him. Then perform a comprehensive medication review, identifying the potential inappropriate medicines and potential prescribing omissions. So polypharmacy, as I told you, it's just not the number. Is it that are we missing the drug that is really required, or are we have to supposed to omit the certain drugs which the patient is taking? So both the things compromise the one arm of the polypharmacy. Then discuss the risk benefits of the drug in the patient context. We always tell patients about 60-65 years regarding the risk of aspirin being taken. So there are alternatives for that, and how that aspirin has risk factors for them in terms of GI bleed, or even if they fall, they develop head injuries and intercerebral bleed. Then come to priorities, whether to stop the drug or reduce the dose, or to continue one or the other drug. And sometimes we have seen that patients are taking diuretics in the night. So that disturbs the whole sleep. So that is how we have to, again, to the priorities and change the schedule, communicate decisions with all the relevant parties. At least his son or daughter-in-law and patient himself must know that this is what was wrong, or this is what was not given, hence we are stopping, or hence we are adding. That should be the role of our clinicians. And of course, we have to monitor and repeat cycle regularly. And again, the cycle continues in the geriatric practice. Now, whenever we prescribe more than 5 drugs, or patient is taking more than 5 medicines, we call it as polypharmacy. It is described as one of the geriatric giant. So even the falls, which we discussed last year, also was considered geriatric giants. And so polypharmacy is one of the geriatric giant. What it means is that this is one leads to iatrogenic problems in the older people. So most of the drugs, they leads to falls, delirium. So that is why it is called geriatric giant. Now, that's what I was telling you, more diseases, more consultants, more medicine. That is what is happening now. For every organ, there is a consultant and he goes on adding medicines. That is what happening now. And it is the onus remains on the geriatrician that which one has to be given and which has to be omitted. Our responsibility mainly in the older people is to avoid drug related problems, because it is we who are directly responsible for any untoward incident that happens because of the drugs. So whenever we write medicines, we should also always ensure that the patient's functional capacity, cognitive status, and disabilities should be considered. We should keep a watch on him, whether he can watch or can he read the medicine, can he see the color strips on the medicine, or if you prescribe him insulin and because of he has got deformities in hands, can he able to take injection on his own? So many issues we have to consider, and sometimes the cognitive status, that's what I told you. The patient is prescribed diuretics in the night and he forgets and he takes a morning and he takes in the night. So he ends up with passing urine whole night. So all these things are very important in the clinical scenario. Now, polypharmacy is not as simple as it is. That is what I was telling you. It is most common iatrogenic disorder. Now, 8.6 million admissions in Europe in every year just because of adverse drug reactions. And 50% of these admissions could have been preventable just because the physician would have been aware. So that is what the impact of polypharmacy takes place. So polypharmacy means, is it too many drugs or drugs for too long time, drugs in exceeding high dose, all of the above, or A only? If anybody is interested to answer, you can answer in the chat box. So WHO, the World Health Organization, defines polypharmacy as routine use of 5 or more medications. This includes over-the-counter, prescription or non-traditional, and complementary medicines used by patient. Even the drugs you prescribe for somebody else, their spouse, they share and they start using it. If they find the spouse is benefiting from that relief, so they will also use the same medicine. So 4, or some books mention 4 and some books mention 5. So we at here clinic, we take as 5 or more medications leads to polypharmacy. Now there is an entity called hyperpolypharmacy. So if persons are taking more than 10 medicines, if a person is taking more than 10 medicines, what we call it is a hyperpolypharmacy. And it is growing now because the population of 80 plus is also growing across globe. India is also facing the same issues. So the population 80 plus is growing more and more, and as they grow old, the comorbidities go on adding. And of course, the medicine rate also, numbers also increases. So what are the risk factors for polypharmacy and hyperpolypharmacy? Is a patient related, as telling you, as age increases, so are the multimorbidities. Physician related, some physicians are having the habit of prescribing many medicines in their prescription paper, and it all depends upon how many number of patients sees, all those things. And of course, we stick to the guidelines. Healthcare system, a lot of guidelines comes. Now, for example, if you take the guidelines for management of heart failure in older patients, 10-15 years back, it was just an beta blocker and a diuretics. Now, what is added is you can add aldactone. Then came that you have to use ARNI. So, okay, so neprilysin inhibitors. Then the new guidelines came just few years back that you can use dapagliflozin as a protective in heart failure. Like that, the guidelines went on adding one or drug to one, and now it has become inevitable. If you follow the guidelines, at least 7 medicines only for heart failure. So you can just think about other comorbidities the patient will be having, like diabetes, stroke, osteoarthritis, anemia, thyroid, so many issues. So whether to follow strict guidelines or it is again depends upon the patient's doctors and condition of the patient. So that we will discuss again later. So as a physician and even for the older people, the goals of this pharmacy prescription should reduce inappropriate polypharmacy. That is what we aim at the geriatric clinic, and ensure appropriate polypharmacy. So what happens because of polypharmacy is we have to ensure the person takes the right medicine and drops the unnecessary medicine, and provides holistic and comprehensive approach. And most important is ensure the adherence. Adherence is very, very important and prevent adverse drug reaction. This should be our priority whenever we look for or whenever prescribe a medicine for the older person. So it is just for you people to read and understand what happens in a prescription in the older people. Whenever there is under prescribing or over prescribing, the patient with polypharmacy have increased likelihood of not receiving potentially beneficial medicines. And this is what is happening in geriatric practice. So we at geriatric clinic always ensure that let the patient bring all the medicines and we check with what they are receiving and what they are avoiding or what they are not purchasing. So what are the issues in older people? Multimorbidities, yes, as we grow old with each disease goes on adding its complications adds and the disabilities that it produces. So definitely the number of comorbidities increases and they seek pill for every ill, which should not be done. Okay. And older people are fond of alternative medicine. They think they are safe, which is untrue. And on the counter medicines and medicines are meant for others are easily available for them and they try them. And some people think of addictive, like if a person is having insomnia, and if you write a small pill which produces sleep, he will ask, will it produce addiction? Then I said, see, sleep is a blissful event that all of us should, humans should have. And till you are living, better have a good sleep. So don't think of addiction. So that is what how the older people issues comes. Now, in my practice, I have seen few fancies in the older people. I just mentioned as fancies. So if I write less medicine, the older people think that this doctor is not intelligent. उसको कुछ समझ में नहीं आया कि शायद उसको मेरी बीमारी समझ इतना कम drugs. That is what the people think, and they think twice before again, you know. And if I tell them to stop this medicine, they say नहीं पहले वाले डॉक्टर बोला है मरने तक लेना है, इसको छोड़ना नहीं, पहले वाला बोला है कि मरने तक लेना है. So it's very difficult sometimes to make them to stop the medicine which is not at all required. And herbal or Ayurvedic, they think that it is, they have no side effects, but that is not true. And that is what I was telling about the sleeping pill addiction. Now, polypharmacy is there, rational or irrational. Now, what is the impact? So why we should discuss about this? Because most of the irrational polypharmacy lead to adverse drug reaction, hospitalization, as I told you, if they just land up in emergencies, increased mortality, it leads to frailty, falls, confusion, incontinence. This is very, very important. And non-adherence to the medicines, non-compliance, there will be huge drug-drug interactions. This makes the patient to stay more in the hospital. And as told you, it leads to undernutrition. They fill their stomach only with these medicines and there's no space for to eat the proper food and nutritious food. And there is an entity called cascade. So what happens if we treat the side effect of the medicine with another drug? We'll discuss that. So these are the impact of polypharmacy, especially irrational polypharmacy on the older people. And we should be very, very careful because we are not only creating falls, confusion, incontinence, adverse drug reactions, and undernourishment. So many problems we are creating in these older people. Now, again, I was telling you 10% due to adverse drug reaction. There's a falls and delirium and increase in the cost and medications. So this is what in a pictorial format that happens. There was a study done in Germany a few years back where there was 57,000 acute admissions in an emergency department. The name of the study was HARM study. So then what happened to what they found was the 3% of this population admitted were due to adverse drug reaction. And the majority of them were 74 years and old. And what was so bothering for us from this study was 91% of these ADRs were predictable, that the physician was probably knowing that this is bound to produce an adverse drug reaction, but still it was prescribed. And what happened with these people is the duration of hospital stay increased by 8 days in these patients. So this is how the polypharmacy has negative impact on the health of the older people. Now, just looking at this, some changes, physiological changes, as we grow old, the pH increases, emptying gastric empty time decreases. There's a reduced splanchnic blood flow, reduced intestinal motility. So all apart from that, there is an undernutrition, dentures, and alcohol intake. So all that affects the absorption of medicine. Now, distribution of medicine takes place. Again, it is disturbed because of increased fat mass, reduced muscle mass, decreased body water, and reduced albumin. So in the older people, even if the person is looking thin and lean, but he will be having fat across the multiple organs. It is the it is the fat which is accumulated across organs, that what we call as visceral fat. So even if we see that old person is thin and lean, doesn't mean that he doesn't have fat. He has more fat, in fact, across the abdominal muscle. That's why when we prescribe fat soluble drugs, we should be very, very careful. Now, there is one concept by sympathy system, that is called 7 steps approach. So when a person comes to us, to older person, what matters most to them? What is that they are having problem? Is the medicine taking right, or what unnecessary medicine he is taking, that we have to check, and how medicines are effective in controlling his symptoms and the disease, and are they coming across any side effects, and is it affordable to him? Just because clinicians, they think that this is a new drug, they keep on adding. And in my practice, what I have seen, most of the older people, they come back to me and they said, I can't afford taking these medicines. Is there any alternative, or can I stop this? So that is what happens. So we always have to share the plan to the patients. Now, I was telling you polypharmacy, rational and irrational. Rational means, yes, it has to be given according to the needs for the patient's diseases. Irrational is one which is not required. Now, again, I have just tried to show you this one of the photograph of the prescription printed. So what is happening in this patient is, this patient is receiving both amitriptyline and noramitriptyline. Both are the drugs of the same group, which ideally we should now never use amitriptyline in the older people. And if you look at the system, that meclobine 1,500 here, meclobine 1,500 here, meclobine 1,500 here. So almost 4,500 microgram of methylcobalamin in this patient is receiving. So when we look at such prescriptions, what best we can do, and how best we can reduce the irrational polypharmacy and make the taking tablets a better experience for the older people. Now, again, if you look at this prescription which we received, this patient was receiving telmisartan, hydrochlorothiazide, and amlodipine, and telmisartan, cilidipine, and metoprolol. So such combinations are not accepted, because both medicines from calcium channel blockers are there, which should not be used. This is also a part of pharmacy practice, what we do in the older people. This old man of 69 years had come to me. He was already taking so many medicines. He was taking 13 medicines. And what we said and do, and take out that what is not at all required, is we remove them, we deprescribe them, and what exactly he requires, we prescribe. All what he required was only these 4 medicines, and instead of 13 medicines. So this is what in geriatric practice we come across, and it becomes our role as a geriatrician to ensure that there is no polypharmacy. Even our students who are trained, and when they come across such cases in patients in their practice, they are sending the photograph. Sir, this is the lady who I come across. Ajay has come 15 medicines. The way she is prescribed, wherever it is prescribed, we are not bothered. But see, now that is what they are acting now. They have stopped all the medicines. Only those medicines which are required, where the patients are also happy, and they come. There is an adherence for that. Now, these are the patients with this. Of course, this is with permission. I am taking showing this photograph. This is an old man, now 84-year active. He takes these medicines. Okay, the numbers are 7 or 8, but these are genuine medicines which he has to take. Okay, so this becomes an appropriate polypharmacy. So this is the guy who takes so many medicines, and though it is not at all required, there are multivitamins, and these are the size of the capsules which he cannot even swallow. But what was his thing in mind that when we ask him why that you are stuck to so many medicines which are not required, the answer was, sir, when I consume all these medicines in a day, I have a confidence that I will get up tomorrow morning. I'll wake up tomorrow morning. So with these things, they are having in the mind that if I take this medicine, I will wake up tomorrow. So this is how, though it is inappropriate, but we have to ask them, why is that you are taking? So again, we get a lot of such photographs coming from our students across India. So these are the medicines the patient is taking and how they have started working on it and solving it. So again, this patient is receiving so many nitrovate, clonazepam, alprazolam, all the three medicines is prescribed. So this is irrational polypharmacy to the larger extent. When we at the geriatric practice, we look at the prescriptions that they are taking. We have to check the prescriptions. Look at this. Apart from the medicines which are prescribed by physician, he on his own is taking nimesulide. And apart from that, Gendubam and gasolflaman, which are sold out of. So this is a drug which again we have to keep in mind. So as an NSAID, patient is receiving hypertension. So again, checking the prescription is also very important. So this is again a overdose of pregabalin that prescription patient is receiving. And of course, we all know that allopathic doctor cannot prescribe Ayurvedic medicines. That becomes a part of quackery by NMC, and so Honorable Supreme Court has given. Now, the most important aspect, what we do in our day-to-day practice is the brown bag review. So what we tell the patient is to bring all the medicines to the clinic. And this is a lady who had come to us. We have brought all the medicines that she was taking, including eye drops, ointments, and non-allopathic medicines. Everything they should bring and show to you. And it is our duty to ensure that sort the irrational drugs. So what she required altogether was only these 5 medicines, but invariably she was taking popping up as and when she required. She was very fond of colors. So color, red, yellow color tablet, red color tablet, all these things they were very fond of. And they used to pop up these medicines which are not of much importance for them. Now, coming to the drug-drug interactions, this is very, very important for all of us to know that when we write ACE inhibitors with potassium supplementations and all, hyperkalemia is the rule. Potassium sparing diuretics is sometimes written. Patient present with emergency medicine with hyperkalemia or hypotension. Digoxin with other antiarrhythmics cause bradycardia. And 2 diuretics, again, electrolyte imbalance in dehydration, especially in summer season. And benzodiazepines can leads to sedation, confusion, and falls. So we always tell the older persons and even our postgraduate students, never ever prescribe alprazolam, never prescribe benzodiazepine. Has a negative effect on the older persons. Now coming to the concept called drug cascades. So what happens in practice is a person receiving amlodipine, written by one physician, he develops pedal edema, he goes to another physician and he writes a diuretics. Okay, so we are treating the side effect of one medicine by another drug. So that is what we call as drug cascades. Pregabalin is advised for 3 or 4 days back. The old man, next day morning, he comes back, comes to our OPD, then I'm having giddiness. The physician lands up in prescribing another medicine, and the patient continues to take this medicine, which produces problems. Amitriptyline, strictly not advised in the older persons, and it leads to hypertension. And if you don't take the history that what patient is taking, then it will end up with adding another antihypertensive drug. So hydrochlorothiazide, if they come with joint pain, always think of gout that is produced by uric acid by hydrochlorothiazide, and better stopping the medicine will always the drug into adverse drug reactions. So like that, there are plenty of cascades that takes place in the older persons, and it is our responsibility to reduce it. So it is imperative that we must take an account of drug-drug interactions, therapeutic cascades, adverse effects like falls, potential inappropriate medications, nutritional deficiencies that this medicine leads, and overprescribing, misprescribing, and underprescribing are happening nowadays with most of the patients and most of the specialist patients being seen. So now coming to the another concept, what is that is potentially omitted or inappropriate medicine, that is what we are talking, and omission. So this lady with hypertension, proteinuria, and diabetes, she was advised metformin and amlodipine. So what is missing Okay, amlodipine is an antihypertensive, but what prevents proteinuria in patients with diabetes is an ACE inhibitor. So this is what was missing. So we have to convince the patient that you can go for an ACE inhibitor rather than amlodipine because it has a preventive, protective effect on kidney as well. So to guide all these things, there are 3 tools that has come to our benefit or rescue, what you can tell. One is what is called as stop criteria and the start criteria and the Beers criteria. So what these criteria or tools help us in appropriate medications to identify, medications to being avoided, medications to avoid in certain circumstances, and to use with caution. So start criteria is one which stands for screening tool to alert doctors to right treatment. So doctors should know whether I am using the right medicines for the right patient and right diagnosis. That is what I give the example. So ACE inhibitors for diabetic and proteinuria, ACE inhibitors for heart failure, that has to be written, prescribed. Okay. Then there is a stop criteria. Stop criteria is screening tool for older persons, potentially inappropriate prescriptions. So if you think that these medicines are not required, yes. So aspirin at the dose of 150 milligram, not required. Okay, like that, they have given calcium channel blockers with chronic constipation. Patient is already having chronic constipation. Avoid adding calcium channel blocker as an antihypertensive, first line antihypertensive. So that this is how the stop and start criteria are there for our rescue to tell us that this drug should not be used and this drug you can use. Beers criteria identify inappropriate prescribing so that we can avoid potentially inappropriate medications. It tells that avoid, it gives in a color in that. So avoid alprazolam, avoid, like they give the concept. Okay, so avoiding the medicines which in the older people is again assisted to us physicians by these criteria. So that is what we do. Steroids, testosterone supplementation should never be done unless the patient is having low testosterone levels. Just because he's frail, just because he's weak, we should not prescribe testosterone. That is what it is. This criteria tells to us. Now, again, if you look at this picture, there are so many irrational polypharmacy taking place. Almost 120 milligram of telmisartan he is receiving. He is receiving 2. One is Ganaton as an prokinetic and another domperidone as a prokinetic. Exit, which I told you, alprazolam should not be used in older person he is receiving. So like that, we get a lot of prescriptions where drugs are being used irrationally. So again, this is another example. Patient is receiving 4 medicines, amlodipine 1, amlodipine with atenolol, and telmisartan with metoprolol, and aspirin with rosuvastatin. So what this tells, atenolol and metoprolol both belongs to the same group of class of drugs, so should be avoided. So this is the common problems that we come across in day-to-day practice in our geriatric OPD. Now coming to the last concept, that is deprescribing. So always we all know that we should never stop beta blockers, benzodiazepines, and SSRIs, selective serotonin receptor inhibitors, suddenly. So it should be tapered. So as a clinician, polypharmacy, when we come across, identify inappropriate, stop those medicines which are not at all required, and consider for which are exactly required. Now, what are the barriers in deprescribing? As I told you, patients, sometimes they are very happy with all the medicines. Some people are not happy. Pharmaceutical advertising has an effect on them that I should take these medicines to keep myself fit, those things. And ease of pill administration has become a problem. And the older people feel that magical power of pill in patient resistance. That is one of the things that they feel that if I stop taking medicine, I will die early. So that is what the concept is. So these are the few barriers in deprescribing. Now, across the world, we talk about antibiotic stewardship. So people are also talking about polypharmacy stewardship. So identify the patient, check the medicines, personalize deprescribing, which are immediately not required. You can deprescribe, which are can be stopped. You can think of that. Support and engagement involving the patients, and always do a collaboration with the stakeholders so that you will not miss any medicines, and always try to ensure that you stop the medicine which is not required. So we as an geriatricians here, we do an once a fortnight brown bag check, take out duplications, stop unnecessary drugs, counsel regarding non-allopathic drugs, and regularly inquire about other medications. They will be taking some medications without your knowledge. So this is what we have put the photograph in my hospital, that if you next time when you come visit to my hospital, bring all the medicines that you are taking, and we will sit and sort out which are the medicines. And in our own practice, I have to improve, enhance the compliance. I have made these plastic bags, zipper bags, and put the stickers on that. So it is all prescribed, printed in English, Kannada, and Marathi or Hindi. And for those who are illiterate, this is the morning, this is the afternoon, and this is the night. So these photographs, we pouches we give them, and the medicines to be taken in the morning, afternoon, and night are added in the respective pouches and given to them. So the principles of pharmacology are no pill for every ill. Whenever you start a new medicine, always start a low dose and go slow. Do no harm should be our priority. Brown bag review should be done every at least once in 6 months. And one size fits all, no, that doesn't make sense. So we have to ensure that the correct drugs are given for the disease. Avoid cascades. Always consider cost, because older people, they can't afford, all of them afford all the medicines. So we have to consider costs. So what is again our role? Think twice before adding another drug. This is very, very important. And involve the caregivers in management of medicines, including the grandchildren's. So this is one of the interesting page which JAMA produces for patient education, and I just put it for information. So again, there is another entity called IGRIMUP, which tells that how to prevent inappropriate polypharmacy. There's a concept called sympathy, which they have brought on book again, where they talk about inappropriate polypharmacy. So with this, I conclude my discussion. And I am very proud of being part of this Baroda Club, academic club, which is the longest serving. And best wishes and regards to all the seniors here. And thank you so much for giving me this opportunity. And I like to end this discussion with the quote from William Osler: "The young physician starts life with 20 drugs for each disease, and the old physician ends with 1 drug for 20 diseases." So that is how, I don't know how true it is nowadays. It is becoming the part of life. So these are my references. Thank you so much for your patience hearing.
Thank you, Dr. Anand. Wonderful, comprehensive talk about polypharmacy in older people, as was expected from you. So you may stop the screen sharing if you're not, because my laptop is not working. I have switched to my mobile phone. I hope you can hear me. Dr. Anand, can you hear me?
Yes, sir. I have stopped screen sharing.
Okay.
Yes.
Okay, good. So now the house is open for discussion. So anybody who has any question, comments are welcome. Yes, Jagdish bhai.
Prescription of statin, saying that it helps in stabilizing endothelium of the blood vessels, even if you have a normal cholesterol levels. Do you agree with that?
Sir, these are the questions most of the older people with us also they ask. And
Yes.
actually, there is see what is given as an prophylaxis is not recommended in this older people, and we treat only what is the main issue. Okay, unless we divide the patients in the risk groups, whether there is a family history, whether any other comorbidities are there which make them to we should add these medicines or not. So depending upon the comorbidities that a person is having, second, the family history of the diseases. Suppose there is an hypercholesterolemia runs in family, or vascular disease runs in family. So then we think that adding a prophylactic dose of rosuvastatin in the patient with hypertension will be beneficial.
Any other question? Dr. Anand,
Yes, sir.
I have a question regarding this polypharmacy.
Yes.
Like for irrational use of antimicrobials, etc. There are a lot of movements being, I mean, they have taken place in at least our academy, that is Indian Academy of Pediatrics. We had a lot of modules, and there are theme-based programs on prevention of antimicrobial abuse.
Yes,
So
sir.
AMR, that is stewardship. Are there any movements across the world or in our country to highlight this issue of polypharmacy in older people?
This is the one way today we have started working, sir. We are trying, this is how we are creating awareness. I should thank you and Baroda Group for having this. Yes, there is a movement now. The Geriatric Society of India and the other academic associations have brought the guidelines. And what we do is we train our own PGs first. Let the mistake should not happen from our department. So that is what we are ensuring. Then we are creating awareness about this among the postgraduate students in medicine. That's all. But as you said, sir, there is no large-scale stewardship program that is happening for polypharmacy.
So, what is the role of medical audit in to help this cause of?
Sir, medical audit does takes place in best of the centers. And that is why the statistics that I shared to you, data that I shared to you, is all because of the audits that has been taking place. In our own hospital, we have an audit for adverse drug reactions. So any adverse drug reaction is reported to the person, nodal officer from the Department of Pharmacology, and he comes and assesses which drug is producing, and that is happening. But it is again the purview of most of the medical colleges that they should have that audit. So we in our college, we are having the audit, sir, for this.
So how much resistance you find from the physicians when you subject to audit?
It is highly resistant. So, so it's very difficult. Sometimes it is difficult to define it as an adverse drug reaction, and then accepting it as an adverse drug reaction again becomes difficult. So so that's why what system was brought in our hospital was, you just drop. They kept in yellow papers in our wards. And if the physician sees that or anybody sees that this is an adverse drug reaction, he just fills the form of 3 lines and puts in the ADR drop box. So nobody can think that there is a resistance, or somebody may feel that why should I inform? So such things are being done to overcome this. But this is a bigger, maybe the larger problem which is beneath the scenario, sir.
Right. Any other comments or questions from the audience?
Good morning, sir. I am a resident, sir, geriatric resident.
Good morning.
Sir, like Anand sir rightly pointed, amitriptyline, it is go-to drug in almost all the neuro OPDs, sir. When patient complains with first-time headache or giddiness, all the neurologists are right away prescribing amitriptyline as the go-to drug, which I would say it, sir.
Yes, that is true. That is what we face those issues. That is why we are creating this awareness.
Yes,
okay.
sir.
So the moment they are put on gabapentin or pregabalin or amitriptyline, which according to our BS criteria should not be used in the older people.
Yes.
So
Yes.
the very next day they'll end up with the issues. And even most of the dermatologists, they use amitriptyline for chronic conditions. So we just tell them in our practice, what we do politely, we go and tell that hereafter don't prescribe amitriptyline, that produces side effects. Because after 1 week, the patient lands up in the geriatric OPD. So that is how the cycle continues. So just a good discussion among our own colleagues. And during my MBBS days and internship, our teachers used to tell that we used to keep drugs unsafe in pregnancy. We used to keep the paper attached to the wall. So these drugs should not be prescribed for a pregnant lady those days.
Yes.
Now we should make this list for all the physicians that please don't prescribe these medicines for older people. At least some 10, 12 common people. It happens in ICU also. We tell the PGs, other department, not to use alprazolam. But next day when the patient goes to bathroom and falls, then they realize, oh, we made a mistake. So that is how these are all preventable problems. But as Satish sir said, this is very difficult to convince the other physicians that don't write this. unless they come across the complications in their own patients. So that is how it is happening. But we at our level, and Nilesh is also from geriatrics, we have to create awareness. And second is, at least we should not do those mistakes. Right.
Yes. Thank you, sir. Thanks.
Dr. Anand, are there any ready-made charts or some apps available where they would give details about drug-to-drug interactions so that physician can cross-check his precision? Are there any such?
Yes, sir. Yes, sir. There are many apps which tell that you add those drugs and it will tell you, use a red mark, don't use this. So there are apps, sir. I don't remember the names now, but there you can download this and you can but who has the time to look for them? Now, so we have recommended our pharmacy college people to produce these things in a medical store. That so whenever prescription is added in that list, so will it tell that there's a larger role of this pharmacist also to identify drug-drug interaction. But again, we land up with problems. And most of the patients, sir, when we have polyconsultation, that is where the problem is. So orthopedics also prescribe antacids and painkillers. The dental surgeon also prescribes antacids and painkillers in a span of 3 or 4 days. Nobody bothers to take the history that are you taking any medicines now. So it goes on adding, and they'll end up with us with severe pain, abdomen, vomiting, and gastritis due to most of the issues. And then we have to sit and sort it out. So there are apps which finds drug-drug interactions. Even most of the physicians, they use in their mobile phone. I will get you back, sir, with those apps.
Yeah, you can share that in the group.
Sure, sir. Sure, sir. But at least what message should go home is number of medicines which are not at all required can be stopped. Irrational should be avoided. Rational, let the physician take the call, treating physician take the call. But irrational, unnecessary multivitamins, unnecessary 2 painkillers, 2 antacids, at least duplication of drugs should be curtailed at any cost. And costly medicines should be at least talk to the patient, a patient attender, because the pension amount remains same, but the cost of medicine goes on increasing. And every year, one new disease adds on. So that puts a burden on the patient's monthly budget. And now they seek for Jan Aushadhi Kendras and all. Again, they don't get the combinations which we prescribe. Again, they'll add up with single medicines. Again, a polypharmacy. So many issues starts popping up. So it's a physician who has to have patience, talk to the stakeholders, involve them, take a collective decision and manage. So that is what takes time in even geriatric practice.
So as you said, as you get older, you get more disease. And of course, there is a rational polypharmacy also. So some may be actually requiring more than 5 medicines. So how do you ensure compliance in them? I mean, are there any apps which are useful to remind the patient, or are there any mechanical arrangements whereby they don't miss out on certain medications?
Yes, sir. This is very simple. In our own mobile phone, Android, most of the patients I have seen, and even doctors, they are doing, they are just putting the alarms at 8 a.m. Take tablet, telmisartan. Okay, then 10 p.m. or take a tablet of this. So they have put in alarm itself in our own mobile phone. And there are reminders also. So if you have an app for medicines app, it tells you a reminder, take medicine, like that. It gives them beep. So the old person, especially those who are staying alone, for them it is beneficial. But again, those who are short of hearing, short of diminished vision, there the challenges lies. So the best app is your own mobile phone. Put the alarms in a day, that 8 o'clock, 9 o'clock, 10 o'clock, what all medicines have to be taken. Put alarm with a voice note that take this medicine. So I have seen many older people, even at my traveling time, that their mobile is buzzing, that take medicine. So in the train and all, we see that. So that is a good idea, and simple and best, cheap and economical. In your own Android phone, you can do that.
And dementia adds to these problems. Often they forget that whether they have taken the medicine or not. Sir,
they forget, and that's why cognition has to be taken in consideration when you write medicines. And we always involve grandchildren in their family in ensuring that person is taking medicine. So I tell the grandchildren that before you go to school, ensure that your grandpa has swallowed these 2 medicines. So morning medicines are at least in his stomach. So afternoon medicines taken care by the daughter-in-law or son. And again, night when the children comes back to school, again they ensure that his grandfather has to pop up this medicine. So with these simple things, because involvement by family members is more important in patients with dementia, because they're bound to forget, and the redistribution of work in the family will always enhance the compliance for medicines, even in the patient who are disabled or having dementia.
Good. So any more questions?
Any experience somebody can share, senior physicians or members here, that I can also learn from you.
Dr. Anand, your video is not on, huh? Somehow I'm not-
Yes, I will answer. I will answer just to enhance the connectivity. I keep it off.
So any comments from other physicians in the audience?
If anybody wants to share their experience, can.
Okay. It seems there are not many
Yes.
questions now. So thank you once again, Dr. Anand. So
Thank
you
you,
have
sir.
promised that once in 6 months you will come back to this club.
Yes.
Maybe somewhere in October you will have another talk.
Okay. Sure, sir.
So
Thanks.
thank you all for joining. Thank you, Dr. Anand.
Thank you for this
It was
opportunity,
really
sir.
very informative and very comprehensive and sort of good messages you have given. There are a lot of messages in the chat box complimenting for you for the good information and useful messages that you have given. So
Okay,
thank
sir.
you all. And
Thank you, sir.
we meet next Saturday again. Thank you. Thank you.
Thank you. Thank you all.